Hi everybody. Today I'll be speaking on the neglected elbow instability and its treatment with circumferential ligament reconstruction. So at the outset, I would like to thank the HGOC for giving me this opportunity to share my experience and knowledge. And I also appreciate their efforts for the surgical training, helping people in the developing countries. I have nothing to disclose. So, brief background about me. So, I'm a hand and upper limb surgeon working in one of the cities in India called Bangalore. So, I work in a level 3 trauma center where I deal with a lot of neglected hand injuries. Coming to the brief anatomy of the elbow joint, it's a diathodal joint, and just looking at the anatomy, it looks, more or less stable, unlike our other joints such as shoulder. The intact trochlea notch of the ulna is shown to be responsible for providing 55% of stability to varus stress and extended elbow, and up to 75% of resistance to varus stress and the elbow flexed at 90 degrees. Coming to the anatomy of the ligamentous structures, on the radial side, we have the lateral ulnar collateral complex, and on the medial side, we have the medial collateral ligament. So, in the critical ligament on the radial side is the LUCL. So that goes from the epicondyle region to the supinator crest of the ulna. That is a prime stabilizer. It's called a complex because it involves even the annular ligament and the radial collateral ligament, which goes around the radial head. Now coming to the medial side, we have the anterior, transverse, and the posterior band. Here, the anterior band is supposed to be the critical structure and is the last point to rupture in a totally unstable elbow dislocation. Now we have seen the ligamentous structure. Another critical part of the bony anatomy is the radial head and the coronoid. These are there's a very important skeletal stabilizer because the biceps and the triceps tends to take the forearm backwards. So it acts as a buttress and prevents the elbow going posteriorly. So elbow dislocation, the basic definition is loss of congruity of any joint. So here we also call it by the other term, which is instability, which we'll discuss further. So traditionally, what happens, any instable or a dislocated elbow, we do a closed erection, and basically we are converting it into a stiff joint by immobilizing for a long time. Maybe we tend to immobilize for 4 to 6 weeks, and they become a stiff elbow. Though the joint looks congruent, it is stiff and not useful. So the primary important thing to know about is the primary stabilizer, that is the LUCL and the anterior band of the MCL. These are the critical structures which are very much important to keep the elbow stable. In addition to this, we have secondary structures such as the radial head and the flexor and extensor muscles. So the difference between a normal and a dislocated or a sublux joint is the loss of congruency and stability. So normal joints is congruent and stable, and dislocation is loss of congruity. So instability, it's more of a dynamic condition, where due to movement or mechanical stress, the reduced joint can lose its congruency. That is, it can get dislocated or subluxed. So this is a pathogenesis of elbow dislocation. It's known as circle of Fori, popularized by the Mayo Group. So they say that it starts at the LUCL ligament first, and then it goes to the anterior and the posterior capsule, and then the posterior band of the MCL. Then finally, it's the anterior band of the MCL. When the anterior band of MCL is gone, it remains unstable in respect of the position you immobilize in. In purged, I think it's just involvement of the LUCL and the capsular structures where there is the cornoid purchase into the humeral condyles. So why are we worried about dislocation? What happens if you don't treat them? So this is an example of a terrible triad. You can see the radial head fracture with the dislocation. So see what happens at 5 weeks. There is a totally loss of congruency, degeneration, and arthritis. And this is at 9 months. See, the joint was just complete congruency. So again, the disease progress again depends on multiple factors: the patient age, then the usage. So, we have to, there's no option of leaving it alone. We have to address it in the best way possible. So, instable elbow can be of three types. Okay, one is, which is after the acute dislocation, it is not reduced, so it's stable. So, okay, so what happens? It can be normal if you just do a close reduction. So then the second part is, it is reduced, but it is unstable. It is more of, when you do some particular stress test, you get this instability. The third part is it is not reducible. That's more of a neglected or a persistent dislocation, which is what we're going to discuss further in my talk. So the chronic instability, it can be recurrent and persistence. In the current, what happens is that whenever you do some certain activity or when you do a stress test, the elbow dislocates. Persistent, the joint remains outside or incongruent. So it can be just a soft tissue or a bone, or it could be a combined. So, for example, this is a case of a patient who had a injury dislocated. Though the joint looks more or less congruent, he has this instability. You see this gross instability, global instability with the anterior drawer test. And you see the pivot shift test. You see the joint popping out. This is an example of a recurrent instability. And what happens in persistent instability is that the joint is non-congruent to begin with. So they can present with various symptoms, like for this first patient, she had a global instability she had a good range of motion and a global instability at the elbow. This is another patient, you can see already some dysplastic changes in OA. And be surprised to know that she did have a good range of motion from 0 to more than 110 degrees. Her main complaints are more of end pain and stiffness. So some patients can also present with just a stiff elbow. So coming to the complex elbow dislocation, that is, where the bony component is involved. You see, for example, this patient had a olecranon fracture with radial head fracture. So the surgeon decides to, excise the radial head and then misses to fix the coronoid and he transfixes the joint for 6 weeks. So what happens is then after removing the caver, the joint dislocates because the coronoid and the radial head have the important buttressing or stabilizing factors. So then we had to go back again and to fix the coronoid and replace the radial head. So this is an example of a complex dislocation where just the ligament will not suffice and need to restore the bone anatomy. So you always start with the bone, then go to the ligamentous structures. So coming to the important part of today's talk, where I'll be discussing about how to manage these persistent elbow dislocations or chronic instabilities. So this is one of paper which we wrote, and it is adapted from one Reed's paper on reconstruction. So the indication for the reconstruction. So the it should be any chronic dislocation. I would preferably say less than 6 months. And it also can be used in cases where there is a multidirectional instability or a chronic instability. Though we don't have huge numbers to just see on that timeline, but based on the few cases and contraindications, as we showed, where some patients had dysplastic joints where we cannot just ligament reconstruction will not suffice, and when they have a stiffness and heterotrophic ossification, that is when tend to avoid doing this complex reconstruction. So I'm going to brief on the steps of this ligament reconstruction. So now when you're sure of, you get a very early neglected dislocation. So when you're sure that you will be able to get away with the reconstruction, then we place the patient supine and we harvest the gracilis or a semitendon graft from the leg. And then we place the patient in the lateral decubitus position on a support. So meanwhile, while we're positioning, the other surgeon can prepare the graft, where he can insert an endo button at the one end, and at the leading end, ethibond or a fiber wire can be used. So important thing on the incision is, because the radius, sorry, the humerus and the ulna, they're not straight lines. So when if you make a straight cut, you might miss out on some certain areas, and closure may be difficult. So you have to mark the mid part of the humerus and feel the ulna and then incise it. So it may be, a curvilinear incision or it could be a zigzag incision. So the approach is a straightforward posterior universal approach. So once you open the skin, you have to raise large flaps, so go subcutaneously so that you have a wide exposure. So another critical point here is in the ulnar nerve. Ulnar nerve, it's not going to be same as what you see in a regular approach of the elbow. So in this you can see it's almost in the midline. When you open it, the ulnar nerve is right in the middle of it. So this is a critical step. First, you have to be gentle in your dissection, find the ulnar nerve, and tag it and isolate it. Next comes the triceps. We have to, just like how you do a triceps sparing approach, you try to elevate the triceps of the humerus. You can use a, cautery or a periosteum elevator, elevate it completely. So you have to feel you should be able to insinuate your fingers and feel for the triceps muscle. Then you look for the ulnohumeral joint. See, one peculiar thing what you find is you'll find a lot of fibrous tissue on the joint. You'll think that the joint is arthritic or fibrosed. But thing is, once you peel off the tissue gently, either with a knife or a cautery or a periosteum elevator, you can see still a good pristine articular surface. So you elevate it. First, you clear the ulnohumeral joint, and then, if required, you think that if you're not able to still get the proper the vision, then I also tend to elevate the flexor and the extensor origin from the humerus, and we had to even remove or disinsert the fibrosed attachments of the LUCL and MCL from the humerus. So only by doing all this, you can we can do a complete release. This was one of the neglected cases. See, you can see had to release all the tissue, basically denude the humerus, to just to clear off all the structures to get the reduction. So once you visit everything, and then you see you have to try for the reduction. Okay, so now once you release all the tissues, you have to look at the radiohumeral congruity. See here you can see the congruity here and the ulnohumeral congruity on the other side. So this reduction, then you try to move gently, so that there's a smooth gliding. Of course, there could be some instability, but still you should be able to get complete range of motion. The problem is not so easy, because in neglected cases, what happens is the triceps is a main inhibiting factor. So it has gone for a tightening. So they say that, up to 110 degrees, if you can get the flexion, it is good. Then it can stretch over time. The thing is, what happens if you don't get it at least for 90 degrees? Then the various techniques described to release the triceps depending on the amount of flexion you get. So if it's a very minor, we can just do like a aponeurectomy of the triceps. The techniques described such as viva advancement, other things. So you need to get a complete flexion intraoperatively to go to the further step. Suppose if you think that joint is stiff and you cannot do anything more, then I suggest you don't do a ligament reconstruction. Then you go for an external fixator and then come back later for a ligament reconstruction. So once you're happy with the range of motion and the joint congruity, then now you go for the ligament reconstruction. So we need to prepare three tunnels. So first one is a humeral tunnel. So it is just like we don't have these special sets. We normally use the ACL reconstruction set. So there they have these teeth needles where you pass in the intercondylar region, the isometric point, and then you over drill it with a 4 drill bit, and you curate the canals. After the humeral tunnel, this is a humeral tunnel, and then next we have to create two more tunnels. One is from the on the radial side, the supinator crest, the footprint of the LUCL. You make a tunnel, first with the key needle, and then over drill it with a 4 drill bit. And same way, in the other side also at the sublime tubercle, you the footprint of the anterior MCL, you make one more tunnel. So we have three tunnels totally. So you have to be careful. You have to make sure you keep enough margins around the hole, otherwise you can have a blowout. So now you have a graft, with the one end that's the trailing end, we have the endo button attached, and then we have the leading end. So you pass it from the ulnar side of the tunnel and bring it out to the footprint of the LUCL. Okay, then take it back into the humeral canal. So now what here we have is the LUCL ligament or LUCL of the graft. Now you pull this around here tightly and then insert an interferential screw. Okay, then so while doing this part, we have to keep the elbow flexed and in pronation. There is a tension part of the LUCL. Once you're happy with the fixation, then you bring this out here, and then you take now next part is the MCL reconstruction. So now you bring it out through the ulnar side, take it out to the footprint or the sublime tubercle, and bring it on the radial side. Now this forms the MCL. So there are two ways of fixing it. Either you could insert an interferential screw here, or just place a endo button here. So this has to be in flexion and supination. So LUCL in flexion and pronation, MCL in flexion and supination. So once you have the ligament reconstruction in place, so next you have to check the range of motion. Look if there's any subluxation or instability happening. So then you try to suture back the flexor and extensor compartment, the muscles, sorry, how much you can. And then because I feel LUCL is more important, I place a slab in pronation and flexion for 2 weeks. I can also get a radiograph to just check your congruity. Here you can see the elbow is quite congruent. And then you start with the gentle active range of motion after 2 weeks. So if you're in doubt about the tension during the surgery, if you think that still is unstable, we can go for a external fixator. So just because you're applying an external fixator doesn't mean that the reconstruction is not good. Sometimes because of loosening or slackening, there could be some instability that can heal over time. Other option could be to use a hinged elbow and start mobilization. So we just do a protected range of motion for 6 weeks, and then we can allow gradual strengthening after 6 weeks, and by 3 weeks they can get back to their original activity. Cases which I showed the 3 months neglected dislocation. Here you see we did both reconstruction on MCL and LUCL. She had at 3 months, she had a good range of motion up to 100 degrees. And the joint looks quite congruent, though she had some vague pain on the medial side, but she was able to carry her daily activities. So there's another case of similar 3 months on neglected. Here we used the enter button and the screw, and you can see a congruent joint. There's a third case which I showed you before. It was a recurrent instability. You can see that I think part of the MCL was an all-shin fracture. And here we see this is how the screw looks. Here we use the titanium, like the previous one, and we use the two endo buttons. So this is so sometimes we may not be able to do this reconstructive procedures. So what are the alternative options in a neglected elbow dislocation? So sometimes we have a lot of this plastic joints where we just did open reduction external fixator, and you leave the fixator for 6 weeks, and then they have some stiffness, but you have to live with it. Or if possible, you can also do an hinge external fixator where they can you can get a better range of motion. So I have no experience with other techniques, but there are techniques described on interposition arthroplasty, excision arthroplasty, total elbow replacement. But in young patients, we try to always restore and attempt to get whatever range of motion is possible. So I thank you, GOC again. Hope my talk was